Today, we're going to act as medical detectives to decode the fuzzy black and white world of gallbladder ultrasounds. If you've ever stared at a monitor during a scan and thought it just looked like a screen full of static, well, you're in the exact right place. We're going to decode those screens together so you can read them like an absolute pro. So what exactly is your gallbladder hiding? Can you spot the medical clues? Let's figure out how to tell a happy, healthy gallbladder from one that's keeping some pretty painful secrets. Our mission today is straightforward. We want to decode the secrets of the gallbladder by establishing a solid baseline and then spotting the deviations. To get that baseline, we first have to understand a crucial piece of medical lingo, anechoic. This simply means a structure appears completely dark or echo-free on an ultrasound. Why? Because it's filled with fluid, so the sound waves from the probe just sail right through without bouncing back. Okay, let's talk about our baseline. A normal, healthy gallbladder is basically a pear-shaped, fluid-filled pouch tucked safely and quietly beneath the liver. And because it's completely filled with fluid, the inside is beautifully anechoic, just a perfect, dark, clear void. Now, if you take away one thing today, make it this magic number, 3. 3 millimeters. Keeping that specific threshold in mind is absolutely essential when evaluating overall gallbladder health. Bringing this all together gives us our normal baseline checklist. First, the wall thickness has to be safely under that 3 millimeter threshold. The wall should be thin and smooth. Inside that anechoic pouch, absolutely no internal echoes and no stones. And on the outside, there shouldn't be any pericholecystic fluid, which is just the clinical way of saying surrounding fluid. Check all those boxes and you've got yourself a perfectly healthy baseline. But the whole picture changes entirely when mobile obstructions invade that nice, echo-free fluid. Let's look at the intruders. To track these intruders down, we look for echogenic foci. That's just easy wording for bright, solid spots on the scan. Basically, it means a solid object is sitting in the fluid, bouncing sound waves right back at the ultrasound's probe, rather than letting them pass cleanly through. Think about the distinct differences between our two main suspects here, gallstones versus biliary sludge. Gallstones are classic bright spots that actually roll around and move when the patient changes position. Since they're hard and solid, they completely block the sound waves, which creates a dark streak right behind them known as a posterior acoustic shadow. Biliary sludge, on the other hand, is a lot softer. It settles heavily in the dependent or bottom portion of the gallbladder, and because it's soft enough for sound waves to pass through, it leaves absolutely no acoustic shadow. Now, what happens when those intruders stop moving and create a blockage? That brings us to a major crisis, acute cholecystitis, or severe inflammation. A massive diagnostic clue here isn't just visual, it's physical. It's called the sonographic Murphy sign. This happens when the ultrasound probe presses directly over the gallbladder during a scan, and the patient feels a sudden, sharp tenderness. It's a huge physical red flag that correlates perfectly with the inflamed visual scan. So let's run through our acute cholecystitis checklist. Remember our magic number 3? Well, during a crisis, the gallbladder wall swells to greater than 3 millimeters. You'll also see that pericholecystic or surrounding fluid. The gallbladder itself will look completely distended and stretched out, usually because there's a stone impacted right at the neck, trapping everything inside. Pair those visuals with a positive Murphy sign, and you have successfully identified acute cholecystitis. All right, beyond stones and sludge, we can also find fixed structures and visual tricks that can easily fool an untrained eye. Let's explore the oddities. Let's contrast gallstones with polyps. Unlike those mobile gallstones that cast dark shadows, polyps are fixed, echogenic lesions attached directly to the gallbladder wall. They do not roll away when the patient moves, and they don't block sound waves enough to cast a shadow. That total lack of movement and the absence of shadowing, those are your definitive giveaways for a polyp. Another really bizarre oddity is adenomyomatosis. This produces a highly characteristic comet tail artifact. It literally looks like a bright, streaky comet tail shooting right out of the wall. It gives away the diagnosis instantly. Finally, you might just stumble upon a contracted gallbladder. This means the pouch is shrunken down. Usually, this is totally temporary because the patient recently ate a big meal and the gallbladder squeezed out its bile for digestion. But if it's not food-related, that contracted state could point to a permanent structural change from chronic gallbladder disease. To tie this all together, think of this as your diagnostic cheat sheet, summarizing all our clues. You always want to assess wall thickness against that 3 millimeter threshold. Check the lumen for bright spots. Test to see if those spots are mobile. Look closely for dark acoustic shadowing.
and note any surrounding fluid or a positive Murphy sign.
So, as we wrap up this explainer, I want to leave you with this thought. The next time you happen to glance at a fuzzy black and white ultrasound screen, which of these hidden secrets will you decode first? Will it be the acoustic shadow of a gallstone, or maybe the comet tail of an oddity? The clues are all right there, just waiting for you to find them. Keep exploring, keep learning, and I'll catch you on the next one.